Welcome to this Let's Talk Medicine podcast entitled GP Bulk Billing November 2025, Nirvana or Nemesis. I'm Dr. Chris Davis from the Australian Doctors Federation. For decades, highly trained professional general practitioners protected and enhanced our most valuable asset, being our health. Now, political, ideological and commercial interests have ensured a fragmented and corporatized system where disease is the commodity. This corrupted model is predictably contributing to unsustainable demand for costly hospital services that impose ever greater demands on taxpayers and bequeath an ever-increasing debt to future generations. In this podcast, leading practitioners review the perilous state of general practice. Commencing on 1 November 2025, political bulk billing incentives risk further distorting good clinical practice and potentially presage nationalization of general practice. General practice is thus at a critical juncture. A choice of being technicians doing the bidding of bureaucrats and corporates, or being independent professionals guided primarily by the health needs of individual patients. The latter requires patients and governments to sustainably resource GP expertise, time, dedication and practice overheads. Indeed, rewarding GPs for their vital role is the smartest investment we can make, not only for ourselves, but also for our families and our nation. Ultimately, patients are much better off having a GP who is accountable to them rather than the dictates of bureaucrats and corporates. Fair dinkum Australians need to revert to looking after their GP so their GP can look after them rather than third parties. We now go to our GP panel, introduced by Dr. Aniello Iannuzzi, Chair of the Australian Doctors Federation.
Welcome to this third episode of the GP Crisis, brought to you by the Australian Doctors Federation. We have Professor Karen Price, a former president of the RACGP, also a practice principal, and she does ongoing research in general practice, very passionate about general practice. We have Professor Mukesh Haikerwal, past president of the AMA, also a former chairman of the World Medical Association, continues to be actively involved in medical politics, academia and practice, and Dr. Max Mollenkopf, a GP in the Newcastle area and a practice owner for a few years, bringing the perspectives of a younger practice owner. I'm Aniello Iannuzzi, chairman of the Australian Doctors Federation, and I've been a practice owner now for almost 30 years. I'm a rural doctor and also a VMO at a small rural hospital. So welcome to this episode of the GP Crisis. It's been about a year or so since we last convened, and a bit has happened, particularly the 1st of November 2025, with the bulk billing incentives, which the government is telling us are the biggest investment in general practice ever, and also the push towards universal bulk billing with the extra incentives that go with it. So let's get the conversation going. Do we really feel that this is the biggest investment in general practice, in the rebates, in bulk billing? Is this a real thing, or have there been better investments in the past? Let's start from Karen.
I think it's to be seen. I'm not optimistic at all that it's going to be taken up, and I think because there's been a loss of trust from the profession to the government. I think people are wise to be cautious given what's happened over the last decade, in my experience, of denigrating general practice, which is just such a shame for patients. It's such a shame for our health system because all the evidence points otherwise. But we've got this tension that the politicians face with the populist position and ribbon-cutting announcements, and that doesn't sit well with having a long and complicated conversation about complexity in the health system, with health system literacy, with financial literacy. So it's yet, in my view, another announcement, and I think it has some use for those doctors who are already bulk billing in low socioeconomic areas, but it's still a volume-based activity. It's still related to high volume throughput. We still haven't addressed mental health. In fact, we've gone backwards. We haven't addressed complexity and multimorbidity. We haven't addressed aged care. We haven't addressed after hours, and all it is, as I see it, is a quick fix for the pollies, and we're still kicking the can down the road in what could be a genuine reform. And I see very passionate doctors really willing to work with government, often on their own time, to reform the health system, not for their own egos, not for any political votes, but for the benefit of the complex patients that they're seeing.
Thanks, Karen. Mukesh, do you feel this is the biggest investment in general practice, or do you feel it's a furphy?
I think when it was announced, to me, it was a smoke and mirrors exercise. So put a big number on. Wow, that's fantastic. And unfortunately, many people have bought the lie. If they were fed income, they should say, okay, there's 8.5 billion. We're going to try this. And if it doesn't work, we're actually going to not take that money out of health, but then cut it in a different way and use it in a different way. The lie is that all of a sudden $8.5 billion will be spent. It won't be spent. The multiple tiers of complexity to the scheme and the yoking of general practice to this process, it's, by stealth and without any real money, it's trying to nationalize general practice. It's easier to control if it's done in this way. And that's the problem. They don't want to have a conversation with what has been the bedrock of our healthcare system. They don't like the inability to control what they see. And so this is exerting control, nationalizing on the stealth. It's almost, well, you could make an argument that it is a kind of civil conscription. And what really concerns me the most is the people that work in our practices on the front desk are going to get hammered because of misinformation and expectation that cannot be fulfilled.
Thanks, Mukesh. Max, what are your thoughts? Is this the biggest investment in general practice, or do you feel it's something else?
As a younger general practitioner, I guess as a younger practice owner, the colleagues I work with have a series of wants that the government doesn't really deliver on. My colleagues don't want to be told that things are going to be free when in fact they're going to cost something, because they don't want to have to hose down expectations. They don't want to have to disappoint the people in front of them. But alternatively, they also don't want to have to give up their own personal income, give up their own personal time. They would like to see a system where they can provide the care they need for complex patients while also providing fee-for-service care for those that can afford it. And they want more choice in the way they provide care. When did bulk billing become the metric of choice? Why is it that bulk billing is just that metric of choice? And I guess Mukesh also follow up. We talk about kind of nationalism by stealth and things like that. Why has there never been actually a more formal federal approach to sort of salaried and background, general practice fundings? When was it that we assessed over private fee-for-service as the only model that delivers care?
That's right. I think even if we did assume that the whole spend was to occur, and I think we've already heard good reasons why it might not occur and probably won't occur, the whole concept of this being the biggest investment in general practice puzzles me, because I remember back when Howard and Abbott were in charge of health, they brought in the bulk billing incentive at the time. And not only that, at the same time, they increased the GP Medicare rebate from 85% of the schedule fee to 100%. So if you add those two things together, proportionately, that in my mind, or at least the way I calculate it on paper, is a bigger investment in general practice than what we're seeing now with the bulk billing incentive and the PIP incentive, because they're, let's remember, incremental increases against what was already a bulk billing incentive. So I think there's a bit of a game there. And then if you look at the cuts to if you look at the cuts to the care plans and the mental health plans, then you can really say, well, I don't think this is the biggest investment. So even from a purely arithmetic point of view, there are things that can be asked. A couple of you have mentioned nationalisation, and that's something certainly our board at the Australian Doctors Federation has discussed. Some of us are of the view that this is a nationalisation outright, and the 1st of November should be called a nationalisation day. However, to be fair, it's only on general practice at this stage. There is the ability to opt out. Some things are still being excluded, like procedures, so it's not quite there. But it does concern me when prominent GPs like yourselves are using the word nationalisation. Shall we unpack that a bit more? Probably starting with Mukesh.
I think that the notion of nationalisation, to me, it's this putting out a scheme that is in reality not addressing the core problems, putting a fictitious fix and demanding everybody every single person in practice, provides that way of billing for every single person, and puts a decal outside their practice and saying, we're part of Medicare, we are a government program. I think people should be really concerned about it, because the other part of it coming in the background is it's about control. They've never liked us as a profession, as our organizations, because they couldn't control us. They want to control the narrative, and they want to control the way things happen. And I don't want to control us. I don't want them to control my medicine. I, the doctor, need to look after the patient for the best of their needs, with the best of my ability, without interference from government. And this is breaking into that sacrosanct relationship.
As I said, personally, it's kind of a bit of a multi-pronged attack. So I think there's the idea that you have the pressure for bulk billing, then increasing numbers of bulk bills coming from overseas, so you can increase your supply side economics. You can then titrate the number of alternative clinicians. So you have pharmacists, registered nurses, and nurse practitioners also flooding the market. So assuming that we continue to run on this path, there will be a very, very real pressure on practices like mine as they sort of say, well, actually, your business model, unless you go very niche and very sharp, is not going to stand up. So I think it's a really interesting next couple of years to watch how Mark and his team choose to continue to push the market depending on how we respond.
Karen, what do you think about the concept of nationalisation?
I'm totally dismayed by what's happening. They're basically dismantling what is, in fact, an excellent system. And they're doing it exactly as Max and Mukesh have described, in terms of they're cannibalising the good GP. They're cannibalising the therapeutic relationship. They're cannibalising the social contract for some kind of pretty shallow market theory economics of pushing GPs around. And that means they don't respect the professionalism with which we operate. And there's this idea that fee-for-service is some evil child, yet many of us are mixed billing practices where we compassionately bulk bill and subsidise the care, the cost of the care of some of our more vulnerable patients. When there's good evidence around and it's ignored for the sake of political pressure, I think we've got to rethink how and who are in charge of what is, the social fabric of our civilization here in Australia. I really find it morally challenging. And, there's a talk about, when you've got people using bulk billing, there'll be then, in a few months or years, they'll be sort of talking about, well, we've got to approve investment, we've got to approve outcomes, and we'll start getting outcome funded measures. Because, you can't tell from academic literature that general practice is a bedrock. And so away we go on these little merry dances that are government imposed that may have nothing to do with the patient in front of us, nothing to do with what we need to do for that patient in terms of the doctor's agenda. And so it becomes a distorted market. And then we've also mentioned the doctors and doctors, and frankly, that's just an experimentation on the general public without adequate training. And to call those things trials is a bit of a stretch of the research imagination. And they're fragmenting care, which there's no evidence anywhere ever that fragmenting care works. In the UK, you've got to go and see someone for one problem, one thing, one time. It's not convenient, it's not efficient, and it's not good quality. It's all about control.
Thanks, Karen. Yeah. So you've all talked about the market manipulations, what they're doing now with the incentives. The government is soon mandating all of our data be cloud-based, so presumably that'll make it easier for them to take it all over. Let's remember accreditation and all that is linked to that. And the more accreditation we have to do, and the more the RACGP makes the accreditation standards suit government, the more easy it is for government to eventually just step in and say, hey, we'll take over this show. What about the way that registrars are getting trained, even though it's on the surface college-based, it's all really dictated by the government, and all the payments go through Services Australia, so it's all government. It's no longer getting paid by the colleges. So that's another step. Let's also remember that on the one hand, the government tells us that they're the best friend of Medicare and they're doing everything to protect Medicare. But Medicare, let's remember, should be a patient rebate, but increasingly it's become this hybrid model with these sticks that the GPs are having to suffer in order to get the remuneration up to acceptable standards. Put all together, it will be very easy for one day the government to say, hey, we've got everything where we want it. All we need to do is basically take over the leases of these properties and GP is all ours. Now, that may be seen to be far-fetched by some people, but believe me, with all of those elements, it's not that hard to do anymore. And the more we keep lapping up things like these incentives and the more we keep acquiescing to having government fund all these secondary streams of our income, the more vulnerable we become. So I don't think we're quite there that we can say we're nationalised, but it's not going to be hard to go that extra step and fall off the cliff altogether. You have spoken about bulk billing as a KPI, and I'm really disappointed that the AMA and the college don't go harder on the colleges, I should say, don't go harder on this point, because we're meant to be about standards, we're meant to be about doctor-patient relationship, continuity of care, and yet bulk billing as a KPI, it just makes no sense at all. It's purely a financial marker that can reflect poor care as it can reflect good care. It has no resemblance at all or no correlation at all to the quality of care. So what do you all think about that?
I mean, I commented on this recently, and the college was very strong in their dissatisfaction with me talking about it. I sort of put forward the idea that the college is perhaps struggling in this space because they can't have an opinion because their members do both. So I sort of put forward the idea that the college is going to struggle and always struggle to advocate for billing, given they need to advocate for both bulk billing general practitioners, mixed billing practitioners, and private billing practitioners. And you can't argue on all three of those fronts at the same time and put forward a case to government. The response, both formally and informally, from members of the college was that they will always support clinicians to bill in the way that they suits them at that given time, and that ultimately they will never have a position on whether bulk billing is good or bad or mixed billing is good or bad. So I think they actually have an unanswerable question there.
The thing the government wants a simple way out. Well, that's just ridiculous, because there's no simple way out of funding patients and providing healthcare resources to patients. Because why should someone sitting in a 5-story mansion in Vaucluse be bulk billed? It's just popular. And that means that it takes away resources. If they don't contribute extra money into the system, they take away resources from everybody else. So, I mean, it's a political philosophy about whether or not everyone gets the same, or whether some people pay a little bit more because they can, and that helps all of us in the community when we're down on our luck. I mean, it's a political philosophy, and that's why it's difficult, I think. And also the fact that this idea that government want a simple outcome, I think that's stupid. They know it's silly. The other issue with data, my big issue with data, well, I'll talk about bulk billing, but it's a proxy, and I've said to the government, your proxy, it's a wrong proxy. It's not a proxy for us. They're not talking to us. They're talking to the patients. They're talking to their electorates. They're talking to what is a populist kind of theory, because people find it hard to determine quality. Remember when Panadine Forte was flying off the chemist shelves and they had to reschedule it for good health reasons. So convenience doesn't equal good health outcomes, and we've got billions of dollars being spent on complementary health medicines which lack evidence. We've got, I just don't believe that there's a need to provide full free service. It's never free because the taxpayer pays for it for healthcare, and we'll have an uncapped demand, which is what happened in the NHS. So it becomes choked and you can't see. There's very good reasons why there's sometimes gap fee in terms of political reasons, and it makes sense in terms of an equity argument, because I'm happy to pay a bit more if someone else who can't pay has that's how our taxation system works, right? We earn more money, you get more tax. And if they're going to make it free, everyone's going to be taxed. So I just think there's a whole silliness about it. But the politicians aren't talking to us. We need to talk about clinical autonomy. We need to talk about the fact that our decisions for healthcare need to be free of government interference. The patient needs to know, with a so-called nationalist system or a bulk billed system, the government is going to be in their room, and the big baby here is data hoovering. The government cannot walk into David Jones and say, give us your data for free. So we're providing curated data using our intellectual property, and it is curated data, and it's patients' data, but it's curated by our training into a usable form for the rest of the health clinicians to do the quick and easy fragmented care that is going to destroy patient care. So just see, there's a whole lot of issues in this, and again, it comes back to the government not respecting the professionalism of our profession and the high degree of training we have in Australia and the high standards with which we perform our job. They have no idea, or they don't care, one or the other.
Well, that was that was the number one point in how we fix general practice. There were the 5 R's, and respect was number 1, wasn't it, in episode 2? For those of you who haven't seen episode 2, Mukesh, what are your thoughts?
Doctors have different ways in which they want to do their billing, and they need to have advocacy for whatever it is that they're doing. And I don't think anyone ever has said don't put the rebates up, whether you're bulk billing or private billing. Nobody said don't put up the rebates. It's the rebates for the patient. The patient then has a reduced out-of-pocket. and their out-of-pockets are going up because the rebate hasn't gone up. And if you prefer not to take an out-of-pocket, it's much more a case for that rebate to go up. So, what I do think is people have become timid because they have other irons in the fire and therefore don't want to kick up, I guess, about some of the directions that have been taken and try and mollify the disdain that should actually be shown for some of the ways forward. There was a very dear friend of mine, a mentor, who still works with Aniello on the ADF, and he always used to talk to us for the Council of General Practice about all these incentives, about jumping for biscuits. In many ways, that's kind of that 10% was increased in terms of the viability of practices. Many people didn't accredit because they didn't care about the PIP because they didn't want to get the yoke. But of course, as push has come to shove, it's become essential to be accredited because otherwise you're not viable. And then you can't get trainees because now they're going to say you couldn't have a trainee unless you're accredited. Fine. Now they're going to say you can't have a trainee unless you're part of the great new scheme, which is yet another part of that problem that we're facing. When I was vice president and also Bill Glasser was president, he always used to say, we're not going to talk about bulk billing rates anymore. And I did the same thing. So for at least 4 years, we refused to talk about bulk billing rates as a proxy for health. And we got a whole lot of change happening because that wasn't our measure. It was a measure politically.
We haven't talked about the chronic complex care. The system rewarded spending the time counselling a suicidal or depressed adolescent as much as it supported someone with a skin cancer to be removed or whatever. We'd see a totally different style of practice. So I think the system's getting exactly the outcomes that it's designed to get, which is this sort of proxy also for efficiency and access without talking about quality and the very many different ways that you need to see patients and the very complex ways that you need to see patients. I mean, I've always been able to share my data. I'm always very open with my patients. They're happy to, see all my results and all that sort of thing. It's not a problem.
We're not good at selling our story, but also we don't have a parallel system within our systems, which is flexible. And we can do it much more now with technology.
Perhaps we should be focusing, what are you doing to meet your users in the middle of their demands? What are you using to move with your younger patients?
Max, on one of your LinkedIn posts, I put that the Medicare rebate that provides sustenance for the clinic and all the staff of the clinic and the mortgages and everything else. It also should be able to supply enough laxity in the system so that you do have free appointments, so that you do have time to educate the next generation, so that you do have time to do your own CPD, and you do have time to work on the practice systems that actually support good quality care. I know Mukesh, when he set up the COVID clinics, that would have taken hours and hours and hours of your and Karen's free time and the practice's free time to get those systems working. But you ended up with an absolutely high quality, state-of-the-art COVID immunisation and testing stations. So, and I think many GPs did that during COVID, but they would have done it on their own free time. But it's becoming harder and harder to do that when your nose is on the grindstone. So I think that we've got to think about how we provide a system that supports quality care.
The payroll tax dance that we have done over time has done tremendous damage to our ability as businesses to actually take a much more systematic approach to caring for patients. So the work we do so hard to have tenant doctors and to not be a sort of one cohesive group and to avoid payroll tax has meant that in a real world, we probably should have lead clinicians, junior clinicians, an employee model within general practice, and as a cohesive group be working towards the outcomes for our community. And there is a great private business model that works behind that. Unfortunately, the tax system is such, and we've sort of had this historical layers of problems that we've brought about for ourselves here that does leave us in a bit of a bind in this sense.
The younger doctors in my generation wanted flexibility to manage the various demands that were on them. So, and then there was Edelsten and all the other stuff that came in. So it was a complex change in our culture that got us to this point. But way back, everyone had a stake pretty much in the practice.
I took over small practice, one GP. He's been there for 40 years. He oversees his population. Fantastic physician. Loved his patients, loved his job, gave everything for it. It effectively took 3 GPs to eventually replace his workload. So I was working 4 days, had someone else come in 2 days, and then another person come in 3 days. And only at that point were we actually meeting the demand that he met. So that's just reflective of our generation do not work in remotely the same way that the generation before. So every year, it's just a recurring problem. And I don't actually know how we answer that within the current system.
Maybe why they've structured it this way. Maybe they need more churn and burn to get through the patient demand. I know that, and I agree with Karen and the likes of Louise Stone, this is only going to promote more churn and burn, what we're seeing from the 1st of November, and it goes against all the talk about continuity and quality. But if there's unmet demand, is that what they're trying to do? This is the excuse they use, of course, for urgent care clinics and all these other clinics they're setting up and their market manipulation. There's demand, it's access, they keep saying. How do we resolve those two issues? On the one hand, everyone's complaining they can't see a GP. I think government says they want bums on seats and more services to occur. But on the other hand, depending on the mood of the health minister and certainly depending on the mood of the colleges and universities, they're saying we need higher quality care, we need care plans, we need GPs to spend more time. It seems like we're getting pulled in two different directions. And furthermore, we have this financial imperative to have to churn and burn to keep our heads above water. And then on the other hand, we have the PSR breathing down our neck and Medicare breathing down our neck if we churn and burn too much. So it's really a tightrope, isn't it?
I mean, ultimately, we can't do it all, right? Like, I would love to be able to sit in front of every single one of my patients and give 100% of myself, but I am deeply unscalable. Ultimately, patient population is growing, needs are growing, and the only way feasibly to end up doing it will still end up being an MDT model or a chain of command model just within primary care. That is not ideal, and that is not perfect care, and that is not gold standard care. But for a group of patients in the community, guideline-based care and base level of care will just have to be appropriate. And then you will need to have a chain of complexity. I think that's actually a death knell to some degree of the way that general practice works currently, and that's not going to work particularly well for the way we like to work. But I can't see another way to scale with the population.
It has to be integrated, Max, and that's the problem. We've got autonomous and parallel streams, and there's, I think Michael Wright calls it the shadow health system, where we've got all these other parallel ways where you have no idea what your patient has done with anyone else, and we've lost the continuity of care. So it's got to be integrated. But I also think this whole idea about MDT teams, multidisciplinary teams, is a bit of a furphy because we've always worked in teams for those patients who had the resources to have them, and they were the better off patients. Not being able to provide the multidisciplinary teams for the most vulnerable groups or the people with the greatest healthcare needs, because their resources weren't, the Medicare resources the government provided weren't available to them in the community. They could go and get physio in the hospital, dietitians in the hospital, educators, diabetes nurse educators in the hospital and so forth, but that once you come out to the community, you can't. So you've got this state and federal gobbling of resources, and the states are taking all those resources where it's much cheaper and more efficient to do it in the community. And we've got a model of care because we've always done it, but not for those people who can't afford the gaps that some of the allied health people are providing.
There's going to be a role for technology to help to sift patients at a certain point. So already the tools exist for us to have sort of intake into a practice and have some degree of technology assistance to help to sort some patient complaints. This is not universal. This does not suit complex patients. This does not suit culturally and linguistically diverse. Well, maybe it probably does actually to some degree, but this does not suit a lot of patients, but it does suit some patients, and we can get efficiency gains. So I do think we need to do some navel gazing as a profession about how we will be more efficient in this same landscape. I'm all for telling the
Or die.
That's going to be interesting, though, isn't it? Because here we have this push towards bulk billing and high turnover. Medicare is quite unforgiving when it comes to compliance. So if you do something like you've just described and say AI is triaging a patient for 10 minutes and then you touch the patient for 5 minutes, how do we remunerate that 10 minutes? How do we factor that in?
I mean, the government already leaves loopholes for this. But within the 965 scheme and the way I work currently, I now just do my standard consultation with the patient where I provide the excellent care that I always provide, going through their risk factors, their history, and where we go next. But instead of them doing a bit of a furphy of half an hour with the practice nurse beforehand for her or him to write some goals that I might not agree with, it actually just reflects the consultation. I just didn't have to do the compliance. The AI did the compliance for me.
That's right.
So there is the flip side of it.
Yeah, but at the moment we don't have that flexibility within the item numbers. So for a care plan and a health assessment, that's permitted, but for a general consultation, that's not. So if you've got a medical student or a nurse triaging for you, strictly speaking, it's only the time you spend with the patient that allows for that. And now, as we push towards this universal bulk billing that the government wants us to do, that sort of thing you've proposed becomes even less feasible. In a mixed billing model or private billing model, you can do those sorts of things. And we've talked about what Michael Wright says is that parallel health economy. That is true, but compliance, and we'll talk more about compliance now. We've talked about it in previous episodes. How do we comply with the Medicare rules as they are, universal bulk billing? As soon as you try to do something innovative like you've just proposed, which necessitates having to make a patient pay, you fall foul of this 12.5% bonus that they're proposing. How's the government going to react to this? And this is, I think, one of the reasons why the uptake of this universal bulk billing is going to be interesting to watch. I think everyone's going to be very interested to see how strict the government's going to be, what loopholes are going to emerge, how punitive the PSR is going to be when it comes to these things. It's really uncharted waters. And I know a lot of GPs I talk to are very scared, and they're not going to jump into this out of fear more than anything else. Even though the numbers in some areas may be tantalising, there are too many risks. There is too much chance of a new government altering item numbers further, or the bulk billing incentive may alter further. And once you're signed up, it's going to be very hard to untangle yourself.
The other thing from a business point of view is these constant changes are eroding the ability of practice managers and doctors to innovate over time, because just as soon as you get your system set up, someone else has a harebrained idea and something else comes up and you've got to rechange your nursing, you've got to maybe sack some staff and put on other staff. It's just not good for the continuity of the business plans that you've set up to try and make your practice work well with the quality cares. I think the department and the governments of the day, whoever they are, have got to think that through too and work more carefully with the profession to actually preserve, because it's cognitively demanding trying to rechange your practice systems all the time. I mean, maybe I'm getting older, but list of patients, that's hard work.
We are so on the nose as a profession, they don't bother to tell us.
They keep thinking medicine's a task, so they don't talk about the system. And without doing that, they're always going to fail long.
One thing that we should be asking for, and unfortunately the AMA and the colleges don't drum this hard enough, is the rebate. It all gets down to the rebate. We have all this money being diverted to PIP, urgent care clinics, accreditation, every little thing. So there's money for everything. If all that money actually stayed with the patient, because it should be the patient's money, they're the ones paying the tax, the rebate would be much, much higher. The bulk billing rate would also be much, much higher. So getting back to what Karen said, if you're owning a practice or setting up a practice, the only things you can really rely upon are those consultation item numbers. Everything else is too subject to political winds of the day. Clients' costs are too getting higher and higher. The only thing you can be sure of is if I see a patient for this long, I'm going to get this much back if I bulk bill, or the patient's going to get this much rebated if I private bill. That's what you build your business model on. Everything else is a risk, way too risky. And then we wonder why no one invests. And when organisations such as ours say, well, the rebate needs to be tripled or quadrupled, the AMA and the colleges say, oh, how can you say that? Well, you can say that because all the money's been diverted away from where it should be, and that's the rebate. And if you made the rebate decent, you'd see suddenly a lot more investment from young doctors in general practice, a lot more people more settled in their career, knowing that they don't have to look for all these side hustles. And I think things would be a lot more stable.
Increase the rebate, increase the pie of funding, not just sitting at 5%. Let's double it or triple it and slowly segue it away from the hospitals, because we know we can do preventative care. The other thing we should ask for is dispensing rights, so that we can actually be convenient for the patient when they come in with a UTI. We can give them their triprim or antibiotic if they need it. We can dispense that after hours. What was the other thing? And also we should make sure that we mandate that GP clinics can only be owned by GPs.
One of the dark sides of this 1st of November thing that's coming up that I think we do need to touch on is the division it's caused within some practices. I think that's been a really sad feature of this. The fact that some doctors who believe in mixed billing or private billing are going to be cast out of some practices, or they're going to be made to feel like pariahs. I feel that's a really sad feature. Have any of you seen any of that happening yourselves?
In Victoria, model serving populations that were underprivileged, worked out, surprise, surprise, that if you run it purely on a bulk bill model, you can't make ends meet. So there's a bunch of doctors being made redundant.
One of the biggest challenges about mixed billing practices. And look, in the end, if there needs to be a formal split between bulk billing and private billing, and this forces it, it's actually sad to see that people will have to move, but that's also probably something that needed to happen anyway.
We'll have a concierge model and we'll have basically a bulk build model.
We've also heard reports at the ADF that some of the corporate practices are already planning on having, you walk in this door and that's our universal bulk billing clinic, but you walk in that door and that's our private billing clinic owned by separate trusts or separate companies, still under the one roof. It's going to be interesting how the government deals with those things because legally they're two separate businesses. Oh, but let's not forget there'll be a sticker on one door and not a sticker on another door. Does anybody want to talk about the stickers now? The stickers are something that is something that caught a lot of people by surprise. And for those of you in the audience who don't know about the stickers, those who signed up to the universal bulk billing chasing the money have now been sent these stickers that they must display in prominent locations, and the government's going to be checking the compliance. And if they don't put the stickers up within a certain amount of time and within a certain then they risk losing the bulk billing incentives that they've signed up for.
We've got this amazing political power, which we're not using, and we should be using it the other way because they're using our practices as a government-sponsored advertising agency for some poorly implemented policy that's fragmenting the patient's care. So, I mean, we've got to think smartly about what they're doing. They're using us in their political process to get re-elected by using advertising booth.
Labor is synonymous with Medicare, therefore, by making Medicare appear everywhere, that is synonymous with Labor success.
One of the other things that is tied up with all of this is the My Medicare and the patient registration, because increasingly we're going to see a lot of these more lucrative item numbers and these bonus payments linked to My Medicare. Eventually, I can see that My Medicare is going to be linked with bulk billing just full stop. So if you want to be bulk billed and you're not My Medicared in a practice, well, you're not going to get bulk billed. Where do all of you see My Medicare going in all of this?
My Medicare was a bad implementation of one of the recommendations from the Commission, which was about having a way to address those people who are not having their needs met by the current system of fee-for-service. And the idea was it's a voluntary registration and there will be some benefits accruing to being registered. What's happened, of course, is that there's no real benefits apart from getting a longer telehealth consultation accrued. The bureaucracy is about to escalate in that process, and it's yet another layer of bureaucracy, red tape, and reducing patient choice, but also binding the doctor to government processes, not binding the doctor to looking after the patient properly. So I just think that they, if they want to break away from the voluntary bit, actually not giving any benefits, then this is going to make what's a bad system worse.
And hospital workers, doctors, they often get very complex patients who claim they have no GP, and they do the circle of the public hospitals and utilise resources. They need a good GP. That's what they need. But they claim they can't get one, but they can't get one they can afford, I think. I think that's what it is. So there's a certain percentage of the population using up a lot of health resources that My Medicare might address. But again, it all comes down to implementation and ongoing iterations of excellence rather than this hard-lined, you'll do as we say, which is, it just doesn't work as a system of healthcare that we're happy to provide and work with government because we like our job and we like our patients, but are being treated like we're jumping for biscuits, Mukesh, in your term, is just not helpful for reform.
I think in practice, we're already seeing a run on My Medicare registrations as a way of ring-fencing your patient populations, which has been an interesting kind of market shift. There's been the initial slow start. I think it was the GPCC MPs that really kind of led to a lot of practices suddenly deciding that they needed to stake their claim around their patients and sort of bolt them into their system. I still believe that the idea of trying to link a patient to a general practitioner for continuity of care is actually quite a pleasant idea. It's just been lost in competing interests and bureaucracy and everything else. Ultimately, it's just been poorly delivered and we're just kind of struggling our way through at the moment.
And we haven't talked about the fact that we still have a fragmented system. Even if you look at none of these issues that we've talked about, we've still got a state system that's gobbling up funds, getting bigger and bigger and bigger and bloated. and a community system, including aged care and the community mental health care, that is being starved. And that is not a system. That is a poor governance arrangement between the states and the federal government. And that, I think, I've always said that's one of the most pernicious effects on our health system. If the hospital recognised the community physicians and the work that we do, we'd be much more cooperative within a system, and the patients would have a much more seamless experience.
One of the things we've always said about that issue is, yes, of course, there needs to be a governance approach. From a day-to-day and clinical approach, one way to address that is to look at what happens in the smaller towns where the GPs actually fulfill both roles. And it's a shame that we've lost that from regional and urban centres, because if you had the GPs more active in the bigger hospitals, a lot of those things would actually be sorted out at the grassroots. And it's I think one of the great shames. Australian medicine, and we're recording this. I know some of you will listen to this down the track, but we're recording this only a few days after the death of Professor John Murtagh, and we were lucky enough to interview him a couple of years ago for this series, the Let's Talk Medicine series, and these are themes that even he touched on, and he felt that it would be a great thing for general practice and Australian medicine for GPs to have, once again, a greater involvement in hospitals and procedural medicine. Interestingly, he too mentioned that greater remuneration and less government interference would be other important ways to improve general practice. So even the icon of Australian medicine.
Let's pay tribute to him. He was let's pay tribute to him, because he was a great visionary and one of the greatest GPs we've seen in Australia. His professionalism and the gentleman GP approach he had, and he was out in the rural areas and teaching and educating, and so passionate. And independent, very independent thinker. I said to John, mate, you were a bit of a punk when you were young, because he had to be. He had to bring general practice into universities and to make a claim that general practice was its own distinct profession, and to get the respect that he got, he had to be. And I think that's a lesson for us all.
Yeah, we need greater respect for general practice, and hopefully things sort themselves out. Well, thank you to all of you for participating in this podcast. I think we've touched on some important themes. The 1st of November has once again made us think about the importance of general practice in Australia and its viability. We've hopefully unpacked for our audience why the changes on the 1st of November may not quite work for some practices, and why perhaps patients may need to think hard about why the propaganda may not match up with what they're seeing on the ground. Your insights are really valuable. Your clinical experience is greatly appreciated in all of this. Any parting thoughts before we close? Max?
I think government will always be government, and government will always end up doing what is best for their re-election chances. So if we as general practice can continue to learn from the public about what they need and deliver it in ways that maintains our professionalism, our governance, our clinical standards, then we're always going to be a better place moving forward than just trying to scream into the abyss that is the Department of Health.
Very good. Karen, your parting thoughts?
To all of my colleagues out there listening, your advocacy is so important, and your best advocacy is to your patients, providing quality care, excellent care in every way that you can deliver. To be proud of your profession and let the patient do the talking for you, and make sure that they know who to talk to, and that's their local MP.
Thank you.
Mine is, you look after patients and they look after you. And that's really where that access has to be.
Which all gets back to why the Australian Doctors Association is in existence. We believe that the doctor-patient relationship should be first and foremost. That's what it's all about. We're the patient's doctor, not the government's doctor, and that's the way it's meant to be. Thanks very much, and we hope you enjoyed this podcast.
Thanks so much, Aniello.
Thank you.